it's a great pleasure to be talking to this group today, and thank you very much for inviting me. And I'm going to talk to you a little bit about skin lesions, and I actually found this quite a difficult talk to write, so I hope that it will tick the box for you. Now, why isn't this moving down? Just hang on a minute. Right, okay, that's fine. So what am I going to cover today? Well, I'm going to talk about the skin lesions that you're most likely to see. I'm going to lead into a little bit about skin cancers. I'd like to give you some tips about assessing a skin lesion, particularly with relevance to the history. And I think for you that are working in an environment where you may encounter the type of lesion that you see on this picture, I think you need to be able to ask yourselves, what are the tips around whether or not it's cancer? I'll also talk a little bit about skin lesion referral pathways. And as I'm clinical lead for NHS England for dermatology outpatient transformation and recovery, we're doing some work on teledermatology and artificial intelligence, which I'll just give you a quick update on. And if we've time, we'll have some sample cases. Okay, so what I'm going to do when I talk you through this is I want you to try and remember your diagram of the skin. And this may be a long time ago for many of you, and you may never actually have seen a diagram of how the skin looks down the microscope. But this is a very important diagram, and we're going to work through the different layers of it in the context of common skin lesions. So at the top, we've got the epidermis, and the epidermis has two key cells in there. It has keratinocytes and melanocytes, and we'll work through the different lesions that we see from these different parts of the skin. And I still, even as a very experienced consultant, if I look at a skin lesion and I can't work out what it is, I'll often think about the different layers of the skin to try and work it out. Really sorry, I've got a Trust laptop here and it's not allowing me to advance very quickly. I apologize. Okay, this is a question that I ask the students often that I teach, and I think it's just a principle that I want to get across to you. I ask students, we hear patients come in and they say, I've got a mole. Most of the patients that came into my clinic this morning said, I've got a mole and it's changing. And I want you to move away from the mole terminology. A mole is a brown animal that goes under the ground. So if we're looking at what is a mole, the first thing that I want to understand is, and I want to say, is that this is a pigmented lesion. So we talk about pigmented lesions once we move into this away from the mole, and the mole being the brown animal, we move into this description of lesions as being pigmented, and then we ask the question, why is the lesion pigmented? So we're going to talk a little bit about lesions that are derived from melanocytes. And if you remember from your anatomy of the skin, melanocytes are these cells that produce melanin. So in people with rich skin tones, melanocytes will produce a lot of melanin. And in the summer, if we don't wear our sunscreens and we go out into the sun, we will tickle up our melanosomes and they will produce pigment layers within the skin. So I've shown you 3 examples there of lesions that are pigmented lesions, and the area that they're derived from is the epidermis, and they are melanocytic lesions. And the topmost of these is, it looks a little bit funny, but it's got a nice, what we call a fried egg sign. It's got pigment in the middle and then slightly paler pigment on the outside. And then beneath that in the middle, we've got a lesion which many of you may see. You might see this on your elderly caseload, a variably pigmented lesion. Bit more worried about that. That might be a precancerous lesion. And then the bottom lesion is a melanoma, which is larger, it's very variably pigmented, and it's got an irregular outline. And I think many of you, if you saw that on one of your patients, would realize that there was a problem with that. Now, I've included this slide because I wanted to demonstrate to you and just reassure you that in some situations, our melanocytic lesion, we used to call them moles, but we're calling them melanocytic lesions made of melanocytes, can change and evolve. And many of you may have seen this with your children, if you've got young families. Suddenly, your child, you notice after you've taken them out of the bath, they've got a new pigmented lesion, and you think, oh my goodness, new mole, this is something to worry about. Maybe I need to get it checked. So I think it's useful to know about the natural history of melanocytic lesions. And these melanocytic nevi often will start off in childhood as what we call junctional lesions, where the pigment cells or melanocytes are at the junction between the epidermis and the dermis, and they can be flat and black and quite worrying. And then they can evolve into what we call a compound nevus, which is when the melanocytes drop down below into the dermis and the overlying skin is raised, or they can actually lose their pigment completely when all the melanocytes drop down into the dermis. So the point of showing you this slide is to show you that if I see a patient in the clinic and they say, this has changed, this lesion has changed, it used to be dark and now it's pale, and I'll be asking them over what period of time has it changed, because you can actually have evolution of benign lesions. But another point to make is that if you had somebody that was in their 30s or 40s, particularly a woman who suddenly developed a lesion like the junctional one on the left-hand side, I would be much more worried, because that's not when we normally would see those. We normally see that sort of appearance in younger patients. And I'll come back to what the worrying signs are that we look at when we're assessing somebody with a pigmented lesion. A bit of a word about melanoma. It does remain quite rare, but you will all be aware that the prevalence and incidence of melanoma has increased, possibly related to short, sharp bursts of sunshine. And the way that these patients will present is with a new or a changing pigmented lesion. And the commonest scenario is that patients present with a new pigmented melanocytic lesion, most commonly on the lower limb in women and on the back or the trunk in men. And you can see from these pictures that the classical melanoma will be variably pigmented. They're usually bigger than 7 millimeters in diameter. But the key features that we worry about are new pigmented melanocytic lesions appearing in people over the age of 30, or lesions that are changing in that age group. I've put the bottom right picture in because we're seeing more and more of this. This is a elderly patient who presents often with a flat brown patch that has been on the forehead for a long time or on light exposed skin, and then suddenly they develop a nodule within this. And the flat brown patch in these elderly patients is a pre-malignant lentigo maligna, and if left can go on sometimes to develop melanoma within it. So if you've got an elderly patient group, cohort, client base, you may identify some people with dark, flat, brown pigmented lesions. And if they're variably pigmented, you may want to seek medical advice for those. So those are our melanocytic lesions. We're now going to go through a range of what we call keratinocytic lesions, in other words, derived from keratinocytes. So the feature of these are they are in the upper epidermis. So they are by nature going to be, because they're higher up and they're made of keratinocyte proliferations, they're going to be crusty. And if you see a crusty lesion, then the likelihood is that it may well be derived from keratinocytes. So there are some examples here that we're going to work through, and some of these are benign and some of them are malignant. This is by far the commonest lesion that we see in our clinics, and they're often sent up on an urgent skin cancer pathway. And if you get your eye into your client group over the next little while, you'll be able to start identifying these. So these are pigmented lesions. In other words, they're dark lesions, but they're quite obviously stuck on to the top of the skin. They're very superficial. They crust, they bleed, they itch. And these are what we call benign seborrheic keratoses. So if we were to describe these, we would say they were keratotic or crusty. Now, these are often multiple. Patients bother that because they're changing and they're dark, that they are cancerous, but these are benign and they're a serious cosmetic nuisance for a lot of people. And unfortunately, if a patient comes in to me on an urgent skin cancer referral and it's one of these, I have to say to them, I'm sorry, this is not a skin cancer and therefore I can't offer any treatment. But they can be quite troublesome for patients. Moving on, the other common lesion that we see which is a superficial lesion and is keratotic again, is an actinic keratosis. And actinic keratoses are due to sun damage. And you'll see this in your elderly patients. Commonly, they have a reddish background and then they have this crusted keratotic appearance. If you're looking at a skin lesion and you're thinking, oh, that looks a bit crusty, just translate that into keratotic, and that will make you think of it, is this a seborrheic keratosis or an actinic keratosis? These are often multiple. They get worse in the summer and then they get better often in the winter. There's a big debate about these and whether or not we need to treat all of them, because a tiny, tiny minority of them can go on to become skin cancers. But there's been some very, very large studies suggesting that the vast majority do not go on to become skin cancers. But in some patients where you've got immunosuppression or multiple lesions or a past history of skin cancer, we might be keener to treat these. But by and large, these are not treated. They're diagnosed, and then we have got lots of treatments we can use, but we don't worry too much about them. Moving on though, and you may see this in your patients if you're managing people with lower limb disorders. Moving on, this is an important thing to identify, which is this is called Bowen's disease. And Bowen's disease is kind of the next step. An actinic keratosis will show abnormal cells or abnormal keratinocytes, but we don't worry too much about them. But moving on to Bowen's disease, which is what this is, a well demarcated red plaque on the lower, usually on the lower limb, commonly on the lower limb. These are actually precancerous. So if you have a patch of Bowen's disease, what you've got is a bit like cervical intraepithelial neoplasia or CIN. You've got full thickness epidermal dysplasia, and with time, this could go on to become a skin cancer. And that can sometimes be challenging because we've got an elderly, frail patient with very swollen legs and diabetes, and you identify that they may have Bowen's disease. The risk for the treatment with this is that you may lead to leg ulceration. So you have to balance the risks of the potential development of squamous cell carcinoma with the potential morbidity of your treatments. So it's risks and benefits, and it will depend on a personalized approach. And many of you may be looking at this and thinking, golly, that could just be a patch of psoriasis. And you're absolutely right. This can mimic psoriasis, discoid eczema, or other conditions. So one of the tips is to use something like a combination antifungal topical steroid on these patches for a couple of weeks. And if it doesn't go away, it's likely to be Bowen's disease. And this is an example. This is a patient from the clinic where I saw a 70-year-old man, and he gave a very clear history that he'd had a pink rough patch for many years, and then he suddenly developed this nodule within it. And this is a patch of squamous cell carcinoma arising on a background of Bowen's disease. So it's important to recognize that you do have this risk, but not all Bowen's disease will lead to squamous cell carcinoma, and not all squamous cell carcinoma arises on a background of Bowen's disease. This was a salutary case, I think, many, many years ago. You can see the stitches there are silk, which we wouldn't be using now. I think this may even have been a case that Madeline was involved with in West Hertfordshire when we were both much younger. This was a lady who said she'd been hit by a supermarket trolley and she had a leg ulcer. She was treating it for a very prolonged period and it just didn't get better. So she was referred to us. And you can see why people might have managed that as a leg ulcer, but it's not quite right, is it? And her compression bandaging was good, her treatment was good, but it didn't get better in spite of that. And it's got that rolled edge to it, and the biopsy showed that this was a squamous cell carcinoma. Okay, moving on to our other keratinocyte cancers, and the commonest skin cancer by far is basal cell carcinoma. And indeed, in the clinic this morning, I would have seen half a dozen patients who've either had a BCC or have been presented with a BCC today. This is by far the commonest skin cancer. It is related to accumulated light exposure over the years. It's typically on light exposed skin, slowly enlarging over a period of months or years. These are cancers, they are common, they are malignancies, but they are not metastatic. And the important thing, there's some pictures of them here, the important thing is that once you've had one, you have a 50% chance of getting a second lesion over the next 5 years. So we don't follow these patients up in dermatology, but we give them lots of information to look out for new or second lesions. And I just want to throw in something to the mix here about the management of basal cell carcinoma. It's not uncommon for me to have a patient brought in on a stretcher by ambulance, an elderly, frail patient, often with dementia, unaccompanied, with a basal cell carcinoma, perhaps something on the right, a very small lesion that is completely asymptomatic and not troubling them. And I do think we need to challenge the wisdom that we need to be treating all of these patients. If the lesion isn't bothering at all, then I think you can make best interests, successful best interest decisions, reflecting on what is best for your patients. And it's not always treatment, and it's certainly not always aggressive surgical intervention, which is sometimes advocated by some of my colleagues and certainly by plastic surgeons. So moving on, we're getting to the end now of the common lesions, and we've moved now into the dermis. So we're looking at lesions that derive from fibroblasts, from hair follicles, and from blood vessels. And we'll just do a whistle-stop tour of those. Dermatofibromas are common, and that's why I've included them. They present typically as a fibrous nodule, a really firm nodule on the lower leg of women that is often itchy. These are benign and are almost certainly a reaction to an insect bite and are best left alone. Epidermoid cysts or pilar cysts, you will probably see these. They're benign lesions and they may become inflamed and infected. The commonest sites are scalp, back and chest. Unfortunately, the low priority frameworks that we have around the country mean that it's difficult for these to get excised unless there is any functional or psychological impairment. Unfortunately, though, if they get infected, they can be troublesome. I saw a great case of pyogenic granuloma this morning, and this was it typically occurs on the digits or extremities and is thought to be a reaction to trauma. These are benign lesions that are friable and bleed very easily, and we tend to remove them because they bleed a lot. The patient this morning was a great example. I was teaching, and what often happens is in pregnancy, these grow. And they grow quite quickly, and then after pregnancy they will often involute. And the lady had had a baby 5 weeks ago, and it was indeed shrinking down, but then she traumatized it and it enlarged some more. We always remove these promptly because they bleed a lot, and the differential diagnosis is a non-pigmented melanoma. Many of you will have seen these spider nevi in your children or in pregnant women, and this is just when the blood vessel grows the wrong way. Instead of going parallel with the underside of the skin, the vessel turns and makes a right turn, and you get this dilated vessel. They're benign. So let's talk a little bit. I've given you some background to what sort of lesions we've been talking about, and now we need to think about, so what are the key points in the history? Well, I think it's important to remember age. I've already said to you that some things are commoner in different age groups. So older people are more likely to have our skin cancers. Skin type, lifetime sun exposure. I've just seen a patient with melanoma and multiple skin cancers who spent 16 years of his life in Spain and has got massive amount of sun damage. So in your history, you want to know about lifetime sun exposure. We sometimes ask that question and they say, well, I went to Marbella last year for 2 weeks and I did get a bit sunburnt. It's not that we want to know. We want to know about all of their sun exposure over the years. We want to know how long their lesion has been there. Is it new? Is it congenital? Has it been there for a long while? Has there been any change? And if there has been a change, over what time scale. And I've just put this picture in because I like these lesions, and I wanted you to, I just wanted to share with you. I think this is probably one of the most beautiful lesions in dermatology. It's what we call a keratoacanthoma. And why have I included it? It's because these lesions have a very typical history. They grow very quickly over about 3 months. They often stay for 3 months. And if we leave them, they would probably go within 3 months, but we don't usually leave them because the differential diagnosis is a squamous cell carcinoma. It's this beautifully symmetrical lesion with the central keratin plug, and I always like to include a picture of that. We've talked about crusting and bleeding being a symptom, crusting and itching being a symptom of our seborrheic keratoses. Pain is not a feature of skin lesions. So if a patient comes in and they've got a painful lesion, it's much less likely to be a cancer or anything to worry about, except for the lower picture, where this is a very classical feature of chondrodermatitis nodularis helicis, which basically means inflammation of the cartilage of the ear. And if you have a patient who's got a painful nodule on their ear, it's highly likely to be that condition. And the treatment for that is actually to take the pressure of that with a suitable pillow, what we call a donut pillow. If you have a patient with a lesion and it's not changing, it's highly unlikely to be any cause for concern. But our pointers to skin malignancy, I've already spoken about, will be new changing lesions. Itching alone in a pigmented melanocytic lesion, itching alone is not a feature of malignant change. It would be associated with change in size, shape, or color, but not just itching. There's been some great studies that have looked at whether itching is a feature of melanoma on its own, and it's not, but in other association with other features it may be. Enlarging non-healing lesions, and we want to know about sun exposure, and I've already highlighted the fact that if you've had one skin cancer, you're likely to get another. So your neighbor or your friend rolls up that arm and they say, what do you think about this? And we get this as a lot as healthcare professionals. I had it from a woman at a swimming pool when my children were small. And it's very challenging, actually. But what you want to ask about, is it changing? Is it changing in size, shape, or color? Is it new? And remember that if you're not sure, what we do a lot of is watch and wait. We'll get patients to self-monitor. And you're not going, if it looks fine, waiting 6 or 12 weeks is not going to cause any dramatic change. But you know, this sort of lesion, all of you, if you saw that, you would be worried. It's big, it's got variable pigment, and it's got an irregular outline. So looking at it can help. Just a brief mention of dermoscopy before I move on towards the end of the presentation. Dermoscopy is something that we use a lot of. We don't have a stethoscope in dermatology clinics. We have a dermatoscope, and there's a picture of that at the top. And basically this magnifies what we can see in the skin, and it has massively increased our diagnostic capability. And the picture on the right there is actually a basal cell carcinoma that I had on my cheek. And I had it and it was spotted. I already knew I had it. I was on a trip to Jamaica with 40 dermatologists, and they all wanted to tell me how to treat it and what sort of surgical margins. And one of them took a picture with a dermatoscope and told me what she would do if she saw me in her clinic. Finally, just a little bit, Madeline wanted me to talk a little bit about skin lesion pathways, and I was speaking to you, this is with my hat on as the clinical lead for NHS England, where we've done a lot of work on this. Many of you will be aware, and if you're not, this is important. if you see a patient with a skin lesion that you're bothered about, you need to divide them into whether or not you think it might be a squamous cell carcinoma or melanoma. If you think it's an SCC or melanoma, it goes down the urgent suspected skin cancer pathway, used to be called the 2-week wait referral. If there's a low suspicion of that, then we are using specialist advice and guidance now in most of the dermatology departments. This is basically a service that GPs can use, primary care clinicians can use. It's a two-way interaction supported by images, whereby we look at the pictures and read about the history. If we think it's fine, we can just say, oh, that's fine. If we don't think it's fine, we can book direct to surgery, or we can upgrade to a urgent suspected skin cancer clinic. So images are very important to accompany those advice and guidance referrals. The urgent skin cancer pathway, or the 2-week wait pathway, we're using teledermatology for that as well, although in most systems at present, it is actually a face-to-face interaction. Just an example, advice and guidance and how it can help. So basically, these are some images. This was a very black lesion that was sent in, and the dermoscopic image on the bottom right is a fantastic image for us. So this looks like quite a suspicious black lesion, and it was new, and it was on a leg of a young lady. But if you look at the picture bottom right, this is a classical hemangioma on the dermoscopic image. So we've saved that patient the worry and the trip to hospital. Just a word about artificial intelligence. We have been funding, NHS England is funding some pilot projects of the use of an AI tool in various centres around the country, and you may have come across it. We've got some very good data suggesting that it can exclude benign lesions and reduce the need for patients to be seen by a clinician. We're awaiting a final meta-evaluation of this. It's not in use for inflammatory skin diseases. I don't think it will work yet for your patients if you're suspecting non-healing leg ulcers and cancer, but it will become used, I think, in due course for many of our patients with benign lesions. And that is just a pathway showing where it will sit in our skin cancer referral pathway. A couple of cases which I hope by now you would be alerted to. This is a supermarket trolley injury. And basically what I would be wanting you to notice there is that this is quite a slim leg. The leg doesn't look as if it's got much in the way of venous disease. It's got that keratotic lesion a little bit below the index lesion. This is not a very nice looking lesion. It's a kind of juicy nodule. And I think you wouldn't treat this, I don't think, as a leg ulcer. I think if you'd been called to assess this as a leg ulcer, I hope that you would think about actually this not being quite right. So we would want this to be referred on as an urgent suspected skin cancer referral with pictures that could go on either through advice and guidance, and it would be upgraded to a 2-week wait referral, or the patient could go in straight away on that particular pathway. This is one that caught me out again many years ago. 80-year-old man. I was well up for treating all leg ulcers, and I thought I knew what I was doing. It was when I was a junior consultant, I think. He'd had this leg ulcer down there at the bottom of his leg for about 6 months. His Dopplers were fine, and I just thought, oh, he'll get better with compression bandaging. And he didn't get better. And actually, the striking thing here is that he's got a nice leg, hasn't he? It doesn't look as if he's got much venous disease, and there's something going on up but just below his knee, which looks as if it might be some sort of keratotic business. So basically, there's no changes of venous disease. I think this, the history suggested basal cell carcinoma. If you're really bothered, you could send that on an urgent skin cancer pathway, or you could request an advice and guidance teledermatology request. So in summary, I've given you a whistle-stop tour about some common skin lesions and skin cancers. Necessarily because of time, I've had to keep it relatively short. I've tried to direct it towards the type of things that you might see in your clinical practice, and to give you some tips about how to assess lesions and to think about whether it's cancer or not, and some ideas about skin lesion referral pathways with a couple of example cases. And I will finish there.
That is brilliant. Thank you so much. So I've got a few questions starting to come into the chat box. One that I was just going to ask, it was a question that came through just as a general question to the Society a few weeks back, was about if you've got a patient with a suspected skin lesion that been investigated for potential carcinoma in the lower leg, would you stop compression while they're waiting for that diagnosis?
I don't think so, no, because I think the first thing that I do is if a patient comes in on a suspected skin cancer pathway with a lower leg lesion, the first thing I want to know is that they've had optimal compression therapy before I see that lesion. So it's actually, for me, it's a really important question. Have they been having compression bandaging and has it been done right? It's a bit like the patient who comes in, the patient that comes in with acne and they've stopped all of their treatment, whilst they wait for their appointment. The first thing I do is put them back on their treatment to assess what they're responding to. So I think the answer to that, Claire, is very much you keep that compression on. The other reason for keeping it on is that if I'm going to do a biopsy and they've got swollen legs, I really want their leg to be in as best shape possible. I don't want it to be swollen because that biopsy won't heal then.
That's brilliant. Thank you very much.
Do you agree? I hope you agree.
Yeah, I mean that was the outcome that we anticipate. I mean, I'm no dermatology specialist. I'll like fully put my hands up on that. But you can understand where some people have that concern that when you're compressing, are you going to cause it to spread? But I think
No.
like you're saying, it's no, you need to keep that compression on.
Mm.
So apparently, Lisa said, does the National Wound Care Strategy advise against compression until cancer is ruled out? So that's not. I think that's maybe one of the conversations we've had. I'm not sure on that one.
I'd be surprised. I mean, it's really tough for us if we get somebody in where the compression has been stopped and they've got a swollen leg and you're wondering whether it's cancer. The first thing I want to do is to get the leg back into decent shape, really. I would be disappointed, I think, if the compression had been stopped, really.
Yeah, brilliant. So we've had a question from Pauline. I'm not sure if it's a question or comment, but they've put cryotherapy on temple for Bowen can also cause ulceration.
Correct. So that's a very sensible statement. So all of the treatments for Bowen's disease, the risk is, and that's why I raised the point about risks and benefits, all of the treatments that we use for Bowen's disease can potentially lead to leg ulceration if you've got a leg that is poorly vascularized and changes of venous disease. Absolutely, and very important. So the treatment of choice for people with Bowen's disease, if they have abnormal circulatory changes and skin changes, I would say is photodynamic therapy, because that works best and it gets the best outcome. Cryotherapy can be used, but you would need to do sequential cryotherapy, which is you would do sort of top half, bottom half, or whatever. And that involves quite a few visits to the hospital, which is a bore. There are other topical treatments that you can use, such as Efudix and imiquimod, but they're not ideal and can lead to nasty inflammatory changes. I think the first question you have to ask about Bowen's disease is, do you need to treat it? And if you've got a 95-year-old frail elderly patient who's pretty much at the end of their lives, we just need to think very carefully about some of our interventions in these patients, because you're treating to prevent the development of squamous cell carcinoma. And in actual fact, if a little squamous cell carcinoma arose on a patch of Bowen's disease, you could deal with it then. Now, that story is quite different. If you've got somebody who's 60, 65, who's got all their life ahead of them, of course you would want to intervene in any precancerous situation. But we do need to, I think, increasingly be sharing our decision making with patients, particularly things like Bowen's disease, basal cell carcinoma, and those brown patches, lentigo malignant. If we excise all of those, sometimes we take half the face off, and we have to ask the question, are we doing right by our patients? I've got a very good skin cancer nurse that works with me who pulls us all back all the time. What is the benefit for the patient here? Ask that question and advocates very firmly for patients around too much in the way of intervention.
Brilliant, thank you so much. So we've had another question about Claire Turner said that they've had an increase in patients with removal of BCC down to the scalp, leaving a cavity to the bone, often non-healing. What sort of treatments would you recommend in these situations?
Well, you're going to smile because I would ask my wound care colleagues how to manage it. So I think you're right. This is difficult. And what happens is that, so in Lincolnshire, we have a very rural population and we see lots of BCCs on the head. And we curette a lot of them off exactly for this reason, because if you curette them off, I didn't talk much about the treatments. So you can curette off basal cell carcinomas, and that means you don't go particularly deep. And for small BCCs, it's a great treatment. The alternative is you can excise with a 4mm margin or a 6mm margin and go right down to fascia, which is you're going down to the galea of the scalp. And it's big. It's a big procedure and it's a difficult wound. So I think you have to think about your wound care strategies. I know that our maxillofacial surgeons who do most of our head and neck work for us and do our BCCs, they've got a great wound care team that work alongside them. I couldn't give you any more tip. You know, I really don't know is the answer. I'm a dermatologist. What my job is to prevent them getting big holes like that if it's not necessary.
Lovely, thank you. Yeah, so Pauline's had a similar comment there, saying she's had a non-healing scalp wound cavity, which was down to the bone, but epidermis will not attach to dermis in final healing stages.
It's really difficult, and it's really, really difficult. I think these things need to be thought through in the planning step. And the other point is that it's often difficult if it's not healing. Is it not healing because there's still tumour? And that can sometimes be the case with SCC. So we can finish up biopsying again to see whether it's a recurrent tumour. And then you make it worse. It's probably granulation tissue. I think these are challenging cases. And I think it's a bit about prevention and trying to choose your cases wisely and manage them appropriately. It's probably what you're talking about is when grafts fail. We do quite a lot of ours have grafts, and often those grafts fail in that location. It's challenging.
Yeah. Well, there's a comment from Ruth where they've said they've used a lot of Integra on scalps and honey dressings, so that's something to be there. So Anya said, if we suspect skin cancers such as BCC on patients who are bedbound and unable to get biopsy in hospital, is there any other way of getting diagnosis virtually?
There is. So let's rewind a bit. So you've got a bedbound patient. The question is, yes, I mean, I think to get a diagnosis is not a bad idea, isn't it? Because patients' relatives will want to know what's going on. So yes, if you've got a bedbound patient and you want a diagnosis of a skin lesion, then the best way to deal with that is to get some images, so you take a general image and then a close-up image of the lesion, make sure they're in focus, and then you could send those in on the primary care clinicians or the primary care team can send those in on an advice and guidance pathway, and you probably would get a diagnosis. Ideally, you would have dermoscopic images, but that's just a little bit more difficult if you're in a care home. So you would start with those images. And I think if the message came back with a diagnosis, you then think about with the patient and their families and the people in the care home, you then think about, does this patient need treatment? If it's a BCC, do we need to treat it? Is it causing symptoms? What should we do here? If there isn't a diagnosis, I think you then need to take each individual patient and personalize the situation for them, because if the patient is bedbound and frail, you need to ask the question, why do we need a diagnosis, or do we need a diagnosis? And this is not to suggest that we don't intervene in our elderly, frail patients. It's just to suggest that we ask the question. what is the next step here? If we do this, what will happen next and why are we doing it? That's all. It would need to go via the primary care team, because I don't think that the community services have access to the electronic referral service to use advice and guidance unless it's been negotiated locally. So it would have to go through the primary care clinician. So basically, those images would need to go to the GP, and the GP would need, or the advanced care practitioner at the surgery would need to engage through the specialist advice and guidance service with the local dermatologist. Does that answer the question, Claire?
Yes, yes,
okay?
I think it does.
Yeah.
There was a very similar question in the Q&A box as well about you know, how to manage housebound patients, you know, who can't get to a clinic. So I think that's a similar, you know, answer really, isn't it? You know,
It's
getting good quality photos and sending that to the GP. Yeah,
it is, and it's which is the biggest fish to fry. You know, I saw a chap in the clinic a couple of weeks ago, and he, you know, he'd got lung nodules. He's been discussed at the lung MDT for his lung cancer, and he'd pitched up on an urgent skin cancer referral with a tiny BCC here, and you kind of think, actually, this guy's got enough on his plate without worrying about that. So we kind of parked it. I said, well, I think this is a BCC. It won't spread. It's, you know, let's sort out your lung cancer first and then come back and we can reassess the situation with regards to that.
So which cancers are the ones that really need treating and that spread the fastest? Do they
Okay, so the melanoma is by far the one that we bother about. And interestingly, a chap I saw just before I came on here, he's got widespread sun damage. He's lived in Spain for 20 years. And he's come back. He's got widespread sun damage, and he's had lots of squamous cell carcinoma and basal cell carcinoma. And I saw him 2 weeks ago for another lesion on his arm, which I thought was just going to be another squamous cell carcinoma, which I wasn't too worried about because they don't metastasize greatly. They can, but very low rate. And we curated it off, and it's turned out to be a melanoma. So that consultation today has been more challenging and more difficult because all of his other cancers have been what we call non-melanoma skin cancer or non-keratinocyte. They've been keratinocyte cancers, which means that they're very low grade and unlikely to spread. But the consultation today has been around the fact that he's now got a melanoma, and melanomas are much more likely to spread. So we've got to do some CT staging, and we've got to talk him through further surgery, wide local excisions. So it's melanoma that we worry about, but remember that is much less common than the non-melanoma skin cancers like basal cell carcinoma and squamous cell carcinoma.
Well, thank you so much, Julia. That's been really, really interesting. So I think that's
okay. Thank you very much for having me, and I hope you've all had a great day. Okay. Bye now.